Good evening, everybody. Welcome, everybody, for this subject seminar on peripheral vascular disease or peripheral arterial disease, to be more specific. Uh, I think what we should understand is that peripheral vascular disease many times can be silent, and it is a harbinger or a beacon light for the generalized vascular abnormalities affecting both the coronary, mesenteric, and cerebral circulation. So, peripheral vascular disease has to be taken very seriously, not only for the sake of the limb, for the general, more important, sake of life also. So, I think peripheral vascular disease evaluation is extremely important. Management is also very important. And I'll let Praveen take over and start.
Yes, sir. Good evening to everyone. Today, the topic of discussion is peripheral arterial disease. Peripheral arterial disease can be defined as narrowing and obstruction of antegrade flow of major systemic arteries other than those of cerebral and coronary circulations. Prevalence of it's around 14.5% in patients in more than 69 years of age and around 20% in 8 years and older. The two main causes of peripheral arterial disease can be classified into atherosclerosis and minor non-atherosclerotic disease. Atherosclerotic disease forms around 80% of the cause, and the risk factors of atherosclerosis disease are male gender, smoking, diabetes, hypertension, dyslipidemia, hypercoagulable and hyperviscostate, hyperhomocystinemia, and systemic inflammatory conditions. While coming to non-atherosclerotic disease, they include peripheral emboli, aneurysm from thrombosis, arteritis such as Takayama's disease, thromboangiitis obliterans, genital arteritis, and due to aortic coarctation and endofibrosis of external iliac artery, primary vascular tumors, and pseudoxanthoma elasticum. Clinically, it is classified by two categories, one by Fontaine, in which stage 1 represents asymptomatic, stage 2 intermittent claudication. Stage 2 can be divided into 2A, which is on walking greater than 200 meters, pain occurs, and 2B on walking less than 200 meters. 3, wrist pain, 4 as ulceration or gangrene. Rutherford classified the same into 6 as 0 asymptomatic, 1 mild claudication, 2 moderate and 3 as severe, 4 as wrist pain, 5 as minor ischemic ulceration, and 6 as severe ischemic ulcerations or frank gangrene. Coming to intermittent claudication, it occurs as a result of anaerobic metabolism. The patients will present with symptoms of muscle cramps, fatigue, or pain in the lower legs, and it is induced by walking or exercise, but not present on the first step. It is rapidly relieved by rest in both in sitting and standing position, that is within less than 5 minutes. The intermittent claudication usually settles down by walking because it occurs due to dilution of substance P, which is a cause of pain. And the muscle group affected is classically one anatomical level below the level of arterial disease due to the formation of collateral vessels. From the site of obstruction, by the clinical findings, we can correlate with the site of obstruction as when there is claudication in buttocks, thighs, and calves, the femoral and distal pulses will be absent in the both limbs, and we can hear bruit over the aortic iliac region, and presence with impotence, which is commonly known as Lerich syndrome, and the site of obstruction will be the aortoiliac. When patient present with unilateral claudication on thigh and calf, and bruit or iliac region, and unilateral
Praveen, it's
absence
not bruit,
of
it's bruit.
Bruit. Yes.
Bruit. It's French. Okay, so it's bruit.
Yes,
okay.
Bruit. And with unilateral absence of femoral and distal pulses, the site of obstruction is probably at iliac. And if patient present with unilateral claudication in the calf and femoral pulses palpable with absent distal pulses, the probable site of obstruction is femoropopliteal. And if both femoral and popliteal pulses are palpable with ankle pulses absent, and claudication is in calf and foot, the most probable site of obstruction is distal obstruction. Coming to differentiation between the neurogenic venous and chronic, in neurogenic claudication, patient will have history of back pain, and most common pain description will be tightness in the buttocks. And pain will be after walking or standing for similar time of period, and relief will be on sitting or stooping rather than standing position. In venous claudication, patient will have a history of DVT, and there will be bursting pain in the leg. Usually, it will be in the thigh, and onset will be on walking. There will be delayed relief of pain with rest, and pain will relieve on limb elevation. In osteoarthritis, a patient present with pain immediately on the first step, and pain will be described as aching type of pain, and it is usually variable degree in the walk in the morning. Coming to wrist pain, the pain is it is usually exacerbated by laying down at elevation of foot, and patient characteristically describes that pain will be worst at night when limb is elevated, and if the limb is hanging out of the bed and sleeping in the chair, pain is get relieved. This is due to because of gravity, the blood supply is restored.
Okay. Why do you think that the pain is worse at night?
Sir, limb will be in the elevated position, sir. So there will be absence of gravity, and there will be less blood supply, sir, to the distal end.
Why? Nikita?
Due to motion, like walking and all the activities, there will be an increased blood supply during the day, sir.
Okay.
So that is reduced at night. That is the reason.
Vinod?
Maybe temperatures in the night will be comparatively lesser, which leads to temperatures. Surrounding temperature.
I didn't follow. What is less?
Surrounding temperatures, sir. Climatic.
So that will cause pain.
Vasoconstriction and leads to.
No, I don't think that is the case. Abdul or Sania?
So the same thing. So the activity of person during the day is more. So because of which more blood supply is there. Even though substance P accumulates pain, patient has pain, still because of increased activity, blood supply increases and all the substance P is washed off, so he doesn't have much pain. But during the night, there's no more activity and the blood supply is as such reduced. That's why patient complains of more pain. So this, when the patient puts his foot down by the side of the bed, because of the gravity, some amount of blood is escapes through those narrow portion and the pain is significantly reduced.
Correct. Okay. That is one. Abdul?
So a calf pump mechanism?
No, calf pump is only for blood going up. But how will the calf pump help blood supply?
And at night, maybe because the person is not working, so they are more sensitive to the.
I think
pain.
because there is more focus on the sensations at night, because during the day there is distraction, and at night there is so all other activities have reduced, so there is more focus on the one and pain. And I think the second what Sanya said and what I think Nikita said to some extent is very true. And also there is one decreased sympathetic tone, so the during the night, and that also causes less blood flow, because sympathetic activity is very important, in terms of pumping the blood. So when the sympathetic activity is less, I think there is reduction in blood flow, and hence there is rest pain. So increased perception of pain, reduced washout of the substance P, and less activity, and also decrease sympathetic activity during night, or increase sympathetic activity causing vasoconstriction and less blood flow. Sorry, increase sympathetic activity. I think you need to check if there is any other reason, but definitely this question will be asked. Why is the rest pain worse at night? Okay, so remember this. Okay,
Yes, sir.
carry on.
Coming to chronic limb-threatening ischemia, European Society of Vascular Surgery has defined it as recurring ischemic wrist pain requiring analgesia for greater than 2 weeks, or if there is ulceration or gangrene of foot or toes with ankle systolic pressure less than 50 mm of Hg or toe systolic pressure less than 30 mm of Hg. That is Fontaine's 3 and 4 classification. Society for Vascular Surgery Lower Extremity Threatened Limb, that is SVS WIFI, has classified wound, infection, and foot infection as 3 groups. In wound, classified as grade 0 when there is ischemic wrist pain or no ulcer, grade 1 mild, grade 2 moderate, and grade 3 is severe. And this is the grading. In grade 0, there will be no ulcer and there will be only ischemic wrist pain with no wound, and there will be no gangrene. In grade 1, there will be small shallow ulcers on distal leg or foot with no exposed bone, and it is limited to the distal phalanx. And clinically, it can be salvageable with simple distal amputation, and there will be no presence of gangrene. In grade 2, there will be deeper ulcer with exposed bone or joint or tendon, and shallow heel ulcer without calcaneal involvement. And while the procedure, there will be major tissue loss, and it can be salvageable with multiple distal amputation. And gangrenous changes are limited to the digits. In grade 3, there will be extensive deep ulcer involving forefoot or midfoot and full thickness heel ulcer, and it requires extensive tissue loss, and it is salvageable only with complex foot reconstruction or TMA and flap coverage. And it is associated with extensive gangrene ulcer involving forefoot or midfoot and full thickness heel necrosis.
Okay, there is a good evening, Ballal sir. Good evening.
Evening, sir.
So,
I didn't
so
want
nice
to
to
disturb.
have joined.
I didn't want to disturb. That's why I put it on the chat box, sir.
Yeah. Good evening, sir. And
Good evening, sir.
so causes for rest pain increasing at night. Is there anything that you can
No, I
add, sir?
didn't. Actually, I didn't know the other two. What you said, sympathetic, I didn't know. I always thought it was only the perception because everything else was the same. I'll have to check on this, sir.
Yeah.
Whether there is the increased sympathetic, like your student said. I'm not sure of that, so I can't comment, sir.
Okay. The sir has asked a question in the chat box. Is a chronic limb ischemia similar to chronic limb threatening ischemia?
Because I always thought CLI is critical limb ischemia.
Yeah. See, critical limb ischemia, correct. I think critical limb ischemia is definitely not similar to chronic limb threatening ischemia.
Because the definition he gave was for critical limb ischemia. With the pressure of less than 50 and less than 30 is suggesting critical limb ischemia. I think that has to be seen.
Praveen, you are talking about acute, it's one critical limb ischemia also, right?
Yes, sir. Sir, actually, the definition was given for critical limb threatening ischemia only, sir.
The latest so it is. So it is critical limb ischemia, not chronic limb threatening ischemia.
Yes, sir.
So initially, previously it was called CLI. Now new guidelines have changed it to CTLI.
Okay.
CLTI.
Okay, fine.
Yes,
fine.
sir.
Okay, fine.
Right. Carry on, man.
Yes, sir. And ischemia is graded into 4 grades. In grade 0, the ABI...
Just a minute. Let us... Yes, Nikita. So, the patient comes to you with, symptoms of claudication and some, let us say claudication. How will you, what are the points in history and what will you, examination wise, what are the things you will see? Quickly. Or shall we ask Vinod because he's going for exams? Vinod.
Hello, sir.
Sir,
I'll check for the pulsation, sir, and temperature.
No, don't check. First history.
I'll ask whether the pain is even at the rest or while walking.
Okay.
And
so is it claudication or rest pain?
Yes, sir.
Yes, first differentiation.
And I'll also ask to know the location. I'll ask whether both limbs are involved or single-sided limb is involved. The pain is associated in particular muscles are diffusely involved. Hello.
Carry on.
And temperatures, is he feeling any coolness in the other temperature or numbness or anything?
Okay. Tingling, paresthesia, numbness, loss of sensation. Yes.
Sensation.
Okay. You have to ask for duration of the pain.
Yes.
When did it start? How did it start? Is
Progression.
it rapidly progressive or slowly progressive?
Yes, sir.
It's very important. I think to know the duration of either claudication and onset of rest pain as when it has happened. So it is important to know these things. Duration, okay.
History wise, that's all.
That's all. What about presence of smoking, diabetes, hypertension, obesity,
Yes, sir.
and then other things that he has suggested? It's only very rare, small percentage of patients with coagulability disorders, hypercoagulability disorders, and hyperhomocystinemia. All these things
Yes.
you should know. And
Yes.
smoking, obviously. And other thing very important to also ask is the presence of any cardiac symptoms as well. Dyspnea, orthopnea, dyspnea at rest, and what distances do they get breathless when they walk, when they walk on flat ground or uphill, and then
Yes.
any cerebrovascular symptoms. It's very important because, as I told you, peripheral vascular disease is a good beacon light or a harbinger for generalized vasculopathy, and obviously the other two will kill the patient more acutely or in more definitive way compared to peripheral vascular disease. So it is important to know the status of the rest of the vasculature of the body.
Yes, sir.
So all of these things you should assess. And again, detailed whenever there is peripheral vascular disease, detailed history of how many cigarettes the patient smoked, for how long have they smoked. All of these things become very important. And blood pressure, whether is the blood pressure, how long the blood pressure has been present, well controlled or not well controlled, what medication they are on. Diabetes, same, how long is the patient had diabetes for, and obesity. All of these things are very important to assess the severity of the disease. So the history will give you a lot of indication as to how bad or how manageable is the disease.
Yes.
So that is in the history. Sir Ballal sir, would you like to add anything in the history, sir?
No, sir. No, sir.
Okay. Clinical examination. Vinod.
I'll check for the pulsations and whether the color of the
No.
limbs.
First, nobody goes to check the pulses, man. First, you have to look at the ischemic limb. You have other, many times patients may have had amputations and things, but you look at the limb
Opposite. Yes.
to compare the opposite limb.
Yes.
And tell me about what are the things you look for.
Color of the both
Color
the
of the
limbs,
limb, yes.
and hair, whether both are
Loss of hair, yes.
and muzzle, what do you call it? Tone and
Again,
bulk of the
on
muscle.
inspection, how will you know the tone of the muscle?
Inspection.
Bulk of the muscles. Sorry.
Bulk of the muscle, okay. Is there any wasting? Yes.
Yes. And
You may actually get a little extra points if you start with the gait of the patient. Right? So maybe worthwhile to talk about, first of all, whether there is a limb or he's undergone a major amputation in the past, or whether it's a normal bipedal gait, or you find he's limping on what is the painful entalgic gait. So you may get extra marks with this when you start examination.
Correct.
To tell the examiner, look here, sir, I'm looking for the gait.
Yes.
Very important. I think such a fantastic point that is.
Yes.
So that's why I told you, first of all, whether you have to, quickly comment, has the patient had any previous surgery, amputation, that again, if he has had amputations of one toe, some toes of the other leg, then, your conviction as far as this leg is concerned will be more stronger. So
Yes.
mention, as sir said, gait and position of the patient, whether the patient is comfortable in bed or is he restless and in pain, that you will be able to comment. Then you have to comment on presence of ulceration, presence
Yes.
of gangrene, if there is gangrene, dry gangrene, wet gangrene, loss of toes, guttering of veins, and then, as you said, loss of hair, and also by reduction in the muscle mass. So these are the things you look for on inspection. I'm coming to palpation.
Palpation, I'll take compare the temperatures of both the limbs, sir.
Okay.
And again,
Sometimes you will be able to have a sort of watershed kind of, there will be a cutoff point from underneath which the limb will be colder. It will be warmer above that. So that kind of cutoff point may be present.
yes,
Okay.
and I'll check the pulsations of at different levels of the limbs, sir.
Doctor, it may be worthwhile to confirm that there is wasting if you have seen it on inspection
Yes,
before
correct.
you go on to pulsations.
Okay,
You
sir.
finish off examining the limb as a whole when you palpate,
Yes, sir.
right? And then talk about pulsations.
Okay, sir.
So how do you confirm whether there is wasting?
I'll measure with the tape, sir, both the limbs.
Correct. You have to measure. There should be a objective evidence that there is wasting.
Yes, sir.
So measure the limb at the same level of both limbs. If there
Yes.
is one side is less than the other, then you know that probably that limb is ischemic. Okay.
Mm.
You have to describe the ulcer. If there are any ulcers, gangrene,
Yes,
all
sir.
those things have to be described in detail.
Yes,
Then you have to describe then you feel for the pulses. I think again we'll not go into how do you feel dorsalis, pedis, all that. I think you should know all these things. So feel for pulses all over the body. And other thing is, it is important you should know that you should feel the abdomen for any aneurysms, or either in the abdomen aorta or in the iliac arteries or femoral artery, popliteal artery. Then feel for the carotid to see if there is any carotid bruit, or if you feel any thrill when you palpate the carotid, then there is possible cerebrovascular compromise as well. So all of these things examiners will be noticing. And again, by this one, then pulse, blood pressure in both limbs. You have to both upper limbs you should measure, especially if you are suspecting any other associations like coarctation. But because it's a vascular case, they probably expect you to mention that also.
yes.
One word of
Okay.
caution, I mean, this is undergraduates, but don't, there are a set of examiners who will keep on watching you, whether you're palpating both carotids at the same time. So don't do that,
Yes, sir.
right? It's safer not to, because you might actually produce syncope if the
Correct.
gentleman is
Yes.
Correct.
older, you see. So,
Yeah.
yeah.
Right. So
One, yes.
examination is history and examination is extremely critical, like all cases, but peripheral vascular disease is very important to know whether you are dealing with the acute limb ischemia or chronic limb ischemia. And then the possible level of the history and examination will tell you where is the possible level of the obstruction. Okay, continue, Praveen.
Yes.
Any questions so far? Nikita? Nikita, are you there?
No, sir.
No questions, or you're not there?
No question.
Okay. Sania, any questions?
No, sir, no question.
Okay. Right, Praveen, carry on.
Yes, sir. Similarly, ischemia is graded into 4 grades based on the ankle brachial index, ankle systolic pressure, and toe pressure. If AB is greater than 0.8, it's grade 0. and 0.6 to 0.79 as mild grade 1, 0.4 to 0.59 as moderate grade 2, and less than 0.39 as grade 3, that is severe ischemia.
What is normal ABI, man?
Sir?
What is normal ABI?
0.9, sir.
No.
It's a range, sir. 0.8 to 1.2.
1.4.
0.9 to 1.3, sir.
Yeah, 0.9 to 1.3. Okay.
Yes. And similarly, foot infection is also graded into 4 categories. In grade 0, it is uninfected and there will be no symptoms or signs. In grade 1, there will be mild infection, and infection is defined by presence of at least 2, that is of local swelling or erythema around the ulcer, or local tenderness or pain, or local warmth or purulent discharge. And the infection will be only involving the skin and subcutaneous tissue. In grade 2, that is moderate infection, the infection will be with erythema greater than 2 centimeters, or the involving structure will be deep to the subcutaneous tissue, and there will be no signs of SIRS. In grade 3, there will be severe infection. Along with local infection, there will be signs of SIRS. Based on this wound, ischemia, and foot infection stages, in stage 1, there will be 0% of likelihood of amputation. In stage 2, around 8%, there will be likelihood of amputation. In stage 3, 11%. And in stage 4, there will be 38% of likelihood of amputation. Coming to acute arterial occlusion, it is a sudden occlusion of an artery, and the most common cause is an embolus.
No.
Also, sir?
No. No, I think it's wrong. Abdul, am I right or wrong? The cause for acute arterial occlusion, he says, is embolus.
No,
I
no,
say
sir.
it is wrong.
No, sir. You're right.
Anybody else wants to agree or disagree?
Mostly thrombosis over and already
Correct.
previously.
Acute thrombotic occlusion is much more common. 40% of all acute limb ischemias is due to acute thrombotic occlusion. 30% is due to embolus. So, while embolus is definitely, one of the most important causes for acute arterial occlusion, it is thrombosis on a underlying disease vessel. See, what happens is there is underlying disease vessel, and then some trigger happens, which then causes the plaque to get disrupted, and then there is local release of inflammatory markers and platelet aggregate, and then that causes acute limb ischemia. Okay, carry on.
The other cause of arterial occlusion, as said by sir, is thrombosis, occurs as due to atherosclerotic plaque, but outcome is usually less severe. In embolus, the source of embolus might be the recent myocardial infarct or atrial fibrillation, and it causes severe and dramatic symptoms. But in case of thrombosis, the claudication is worse, but there is no any dramatic event because there is network of collaterals formed as seen in this picture. And acute limb ischemia can be defined as a sudden decrease in blood supply of a previously stable leg of less than 2 weeks duration, resulting in rest pain and other features of severe ischemia and threatening limb viability. And it can be divided into acute when the onset is of 24 hours, and subacute when the onset is from 24 hours to 2 weeks. The clinical presentation of acute limb ischemia is defined by 6 P's, that is pain, paresis, paresthesia, pallor, pulselessness, and poikilothermia.
No, I'm in a class. I'll call you later.
Rutherford had classified the acute limb ischemia into 3 grades. In grade 1, the limb will be viable and there will be no sensory loss and no motor deficit, and both the arterial and venous Doppler signals are audible and there is no immediate threat. In grade 2A, there will be marginally threatened limb and there will be none or minimal sensory loss and no motor deficit, and arterial signals are not inaudible, and if it is promptly treated, the limb can be salvageable. In grade 2B, there is immediately threatened limb and sensory loss is more than the dose, and there will be mild to moderate motor deficit. And arterial Doppler signals are inaudible, and it can be salvageable if there is immediate revascularization. In grade 3, it is irreversible limb ischemia, and there will be profound sensory loss and paralyzed motor deficit, and both the signals are inaudible. And the limb is irreversibly damaged, and it requires major tissue loss and amputation. Coming to the investigation part, the most common investigation initially will be done.
Before we, Vinod, can you tell us how you do ankle brachial pressure? It's an ankle brachial index. How do you do
Sir,
that? You know that?
I'll try, sir. Sir, in the first we'll examine both the upper limbs systolic pressure and then the lower limb systolic pressure, and then we'll divide the systolic pressure of brachial with the ankle, and that will call as ABI.
No, you divide ankle by brachial, not the other way around.
Ankle by brachial, sir.
Okay, and how do you actually measure the blood pressure in the thing?
In the supine position.
You should use a Doppler, man.
Yes,
You know, the
sorry.
hand Doppler.
Yes, sir.
So it is not just using the cuff and using stethoscope. Using the handheld Doppler, you should be able to measure the ABI. Okay,
Yes.
continue.
Yes, sir. By the use of Doppler ultrasound, the ABI is quantitatively assessed, and 0.9 to 1.4 is normal, and less than 0.9 indicates there is hemodynamically significant arterial lesion, and less than 0.4, as previously said, it indicates chronic limb threatening ischemia, and if it is greater than 1.4, it indicates that there is some thickening of arterial wall. It can be due to medial sclerosis or due to calcification of arterial wall causing vessel incompressibility.
This
And
is
the other
commonly
measurement-
seen in where?
Sir,
Where is it commonly seen, this high ABI? But still it is spuriously high. There is limb ischemia, but
diabetes mellitus patients.
correct. Small vessel calcification in diabetes. So you get higher values.
Yes, sir. And the other measurement is toe brachial index. It is preferred because it is rarely affected by the sclerosis, and it can be used in combination with arterial ankle brachial index. And TBI of less than 0.6 indicates significant arterial lesion. And here the pressure is measured at the hallux region. Coming to duplex Doppler ultrasound, it uses B mode ultrasound to provide the image of the vessels, and it has color coding, which allows to visualize the blood flow and turbulence of the blood flow. The limitations of duplex Doppler ultrasound is the aorta-iliac segment is difficult to visualize due to bowel gas or obesity, and the vessels that are heavily calcified will limit the ability of the Doppler ultrasound to accurately assess severity of steno-occlusive disease.
So what is the classical thing that you describe in the Doppler when you talk about the vessel and disease? Vinod, how do they describe the
Triphasic, monophasic, biphasic.
Triphasic. So if there is triphasic flow, that means the disease, this one is the vessel is
normal,
healthy and normal. And if there is
monophasic
or biphasic flow,
yes.
and if there is, what will happen at stenotic level, at a stenosis? What will be the Doppler signal? He's mentioned that no turbulence.
Turbulence.
So you will have turbulence at specific points, which will indicate possible site of stenosis or obstruction. And it will be able to give you the idea of the distal runoff as well. Not as well as the angiogram, but fairly good.
Yes.
Are you aware of the terms, the height and the width, what it is called in the waves, doctor? You know, there are 3 waves described on the positive side here. 3 different arterial waves. The height and the width is called what? Are you aware?
No, sir.
Anybody? I don't know. I don't know who the postgraduate names. I don't know, sir. So
Yeah. Anybody else? Abdul or Sanya?
along the x and the y axis, there are 2 separate things. Have you heard terms when when you write an answer? Have you heard of terms called amplitude and spectrum?
Yes, sir.
So what happens when there is stenosis? What happens to the amplitude? What happens to the spectrum? Or height and width? What happens?
Come on, man. It's simple.
Height increase, width decrease.
How can the height increase, doctor? Common sense tells you that the height has to decrease and the width has to increase.
Amplitude increases.
There is a term called spectral widening.
Spectral widening, yes.
Right? When you write an answer, it's not enough if you write triphasic. Few extra things may help.
Correct. Yeah. Thank you, sir. Carry on.
The other mode of investigation is digital subtraction percutaneous angiography. It involves the injection of radio-opaque dye into the arterial tree, and it provides dynamic arterial flow information. And the complications of this procedure are bleeding, hematoma, false aneurysm formation, thrombosis, arterial dissection, distal embolization, renal dysfunction due to the dye, and allergic reaction to the dye.
See, this is generally not used. When is it used? Angiogram. Anybody?
Sir.
You don't use angiogram as a primary mode of investigation. When do you use it? When you are contemplating therapeutic intervention. See, you know, because it is for you to get the information, there are 2 better modalities which are non-invasive. And you will get all the information that you need. Then if you want to plan intervention, especially in acute limb ischemia, if you are planning to do thrombolysis or suction of the clot or whatever, only then you use the percutaneous angiogram. Valal sir?
Yes, I agree, sir, because there is a non-invasive may, like you said. I think that should have come first in this discussion.
Correct.
Sir.
CT and MR angiogram.
CT or an MR should have come earlier than a DSA, I think, sir.
Yeah.
Today.
Okay, sir.
Go to the next one, man.
Yes.
CT and M. Yeah.
Yes, sir. MR angiogram has the advantage of avoiding the as said previously, the nephrotoxic iodinated contrast material and the radiation, and it has high ability to provide a high resolution 3D images. The limitations of it might be due to claustrophobia and certain metallic implants. And patients with renal dysfunction are at high risk of gadolinium-induced nephrogenic systemic fibrosis. Here in this picture, we can see the stenosis at the level of common iliac artery.
Which side?
Left, sir.
Correct. Okay. So I think, to summarize, you have to use the Doppler. The Doppler will give you the clinical examination first. Doppler will give you an idea where the possible segment of ischemia is, and then you use the either CT or MR angio, which will give you a good roadmap. It will also give you information about the distal runoff, which are the vessels that are diseased. Are there focal or generalized narrowing of the distal vessels? Is there collateral formation? All of this information you will get. So then you can decide as to how you will manage. So if the management is medical, then you have the information that you have and you record it and then medically manage them. If it is vascular intervention, whether it is percutaneous vascular intervention or whether it is surgery, you have to decide, and that is based on the angiogram findings. If you are going to do using angiographic methods, then only you use the percutaneous digital subtraction angiography. Okay, right, carry on.
Sir, your hospital, you do a CT or an MR angio, sir? What do you tell your students?
MR angio, sir, usually.
MR, sir. Okay. Fine, sir. Okay, sir.
Coming to management, initially we'll be starting with the non-surgical management, that is exercise, that thrice weekly program of 30 minutes walking sessions to near maximal pain for a period of at least 6 months, and cessation of smoking, lipid control by
No,
statins.
wait, man. See,
Sir.
this is all undergraduate level. This exercise,
Yes, sir.
you should be able to quote studies which shows how much is the percentage reduction and what is the increase in the distance if you use exercise. Is there any benefit of supervised exercise program compared to just doing some exercise? Anybody? There is golden silence. See, the obviously supervised exercise program, one thing is that you'll ensure that the person is doing the exercise every day, and then you are supervising the distances to make out how far he is able to walk before he gets the claudication, and then you monitor these things and basically advise them how to do this. Basically what you have to tell them is to walk through the pain barrier and then see how far can they walk through the pain barrier before they have to stop. So that means basically what you're trying to do is to develop collateral circulation so that they are then able to walk through the pain barrier initially maybe 10 meters, later 20 meters. So there are enough studies to show that supervised exercise program increases the walking distances anywhere up to 50 to 70 meters, and also the percentage improvement is up to 17 to 23%, something like that. So there are good studies which show that supervised exercise programs are definitely beneficial. Balal sir, anything to add, sir?
No, sir. No, sir.
Okay. See,
Yes.
postgraduate seminar should be, you should be able to, quote evidence base, not just, copy paste from textbooks. That is why whenever you do a journal club or when you do a seminar, you should not only, as Lakshman sir keeps telling you, as postgraduates, textbooks should form about 40-50% of your knowledge. The rest should come from your interaction with the teachers and your assiduous studies of latest journals and and the annals, yearly books, because you will get the latest literature in the current of the current thing. So I think that is how you have to do these things, not just quote from textbooks. Okay. Smoking cessation.
By smoking cessation and lipid controls by the statins, hypertension, diabetic control, and by use of antiplatelets or anticoagulants to reduce the risk of thrombosis.
Is that all?
Coming to
Sorry, yeah. I thought
Sir.
I think there should be some more in that, sir. I think you should talk about a little more about antiplatelets, anticoagulants. Like,
Correct.
sir said, this is a PG seminar.
You can't just say one
Yes.
slide, man. Smoking cessation. How long do you need to stop smoking for you to accrue any identifiable advantage?
20 years.
Yeah, 20 is probably a bit more, 15 years at least.
15, yes, sir.
15 years before you see any major advantage. But what smoking cessation will do is, it will prevent. See, what are the causes for ischemia in smoking, man? What does it do?
It causes hyperviscosity, sir.
Correct. Hyperviscosity is one. Vasospasm is two.
Yes, sir.
And endothelial damage.
Yes, sir.
So all these things add to the. So by smoke cessation, for you to really notice difference, as you said, it will be about 15 years, but it will prevent progression of the disease if you stop smoking. Okay, so that is the thing with smoking. Now come to statins. How does statins help?
Sir,
Do statins help?
Yes, sir, it reduces atherosclerotic plaques formation, sir.
No, it doesn't. It doesn't reduce the plaque formation, man. What does it do?
It stabilizes it, sir.
Correct. Stabilizes the plaque.
Plaques.
So
Yes, sir.
when the plaque is stable, there is less chance of it fracturing, and that leading to endothelial damage and exposure of endothelium, which then releases the inflammatory
Oh.
markers and platelet aggregation. So these are the advantages, if of statins. Statins are known to improve the cardiovascular situation much more than peripheral vascular disease, but there is something like 17 to 23% improvement. So if people who are on statins will have a 23% improvement compared to people who are not on statins, which will be 17. So there is a 5 to 6% improvement in the peripheral vascular disease, what shall we say, incidence. But it is more helpful in patients for cardiac and for cerebrovascular. Okay.
Yes,
Hypertension
sir.
control, again, very important. See, I think you should have quoted, figures like for every single risk factor, because see, non-surgical management forms an extremely important, a large cohort of patients with peripheral vascular disease are managed with, what is called as the best medical management. So best medical therapy, and that is actually the cornerstone of all peripheral vascular disease. Interventions are only about 25 to 30% of patients. The remaining are managed with best medical management. So you should elaborate on all these things. And as sir said, again, hypertension and diabetes control is extremely important, because there is discernible reduction in the progression of ischemia if with good diabetes and hypertension control. Talk about antiplatelet and anticoagulants. Talk about aspirin, clopidogrel, and combination of the two, and the newer anticoagulants.
Sir, at present, the guidelines are 75 mg of clopidogrel or 75 mg of aspirin as an alternative to clopidogrel can be given, sir, to reduce.
Which is better, clopidogrel or aspirin?
Sir, first preference advised as clopidogrel, sir.
Clopidogrel is better compared to aspirin. Yes.
Yes, sir.
Is there any advantage in combination, using combination of clopidogrel and aspirin? Anybody? Sanya?
Not in peripheral vascular disease, sir. Using a combination of those two
No,
doesn't have an
it
advantage.
is shown that if the patient is symptomatic peripheral vascular disease, by combination of aspirin and clopidogrel seems to help. But if it is asymptomatic patient, when the patient has come to you for something else and you evaluated and found that patient has peripheral vascular disease, such patients won't benefit by giving combination of clopidogrel and platelet and aspirin. What about warfarin or the newer anticoagulants, rivaroxaban, and all that. Silence again. Sanya, what is the role of warfarin or the newer anticoagulants?
So those are most commonly used in venous disorders.
No, not venous. They of course, deep vein thrombosis, yes, but they can be used in peripheral vascular disease also.
Okay, sir.
There was a
Again,
question
I
about
think it has in symptomatic patients, they have shown that, especially now, I think warfarin usage is coming down significantly. Why? Can anybody say why warfarin usage is coming down?
Alternative drug, direct thrombin immunity.
Abdul, to speak up, man.
So
Speak up.
better alternatives like direct thrombin inhibitor.
Correct. So that's fine. So, but what is the problem with warfarin?
The reversal, sir.
Not reversal, man.
And
Monitoring.
it takes a lot of time to act.
You need to monitor. You need to have the INR between for peripheral 2.5 to 3.5 to 2.5 to 3.5 times the normal INR, and there are drug interactions, and sometimes there will be irregular therapy will lead to either bleeding or severe bleeding causes cerebrovascular accidents. So monitoring with warfarin is very critical, and many patients may not, it is difficult to monitor them. The newer, as you said, the newer agents are more effective because they are more specific, and also they do not need any monitoring. So that is the advantage of either apixaban or rivaroxaban. Usually those are the two agents that are used. Sir, Ballal sir?
No, sir, there's a question on the chat box, sir, about silestazole, which I think is important, sir.
Yeah. He's not spoken about silestazole.
Phosphodiesterase inhibitor, sir.
Vasodilator.
By
So what is the
inhibiting
role of
platelet.
silestazole?
Improves.
Is it helpful or not helpful?
Help.
Top man. It can be either 50. You will be right 50% of the time.
Helpful.
Why do you think it's helpful?
Vasodilation at least.
What is the mechanism of action?
It will inhibit the phosphodiesterase A2 and leads to vasodilation.
Okay. So it is helpful in patients with symptomatic claudication. Sorry, because it is obviously claudication is symptoms anyway. So not in asymptomatic patients, but symptomatic peripheral vascular disease, it is helpful. Sir, Ballal sir, is there anything to elaborate on?
No, sir. I think he should have made more extensive slides. That's all, sir. It's
correct.
okay.
Yeah.
Yes, sir. Each one, like you said, should have been done more extensively, sir.
And I think evidence base should have been given.
Yeah,
okay.
So. Yes.
Continue.
Next mode of treatment is transluminal angioplasty and stenting. Here, the arterial occlusive disease can be treated by inserting a balloon catheter into the artery and inflating it within a stenosed or occluded segment. This is the balloon catheter. This is deflated and inflated one. And in this picture, we can see the DSA. This is the DSA mode, and with multiple stenosis in the superficial femoral artery. And in second picture, you can see the balloon is inserted and it is inflated. After post balloon angioplasty.
Praveen, very basic question. How
Yes,
do you identify superficial femoral artery and profunda femoral artery? Which is medial, which is lateral, and how do you identify them?
Superficial is medial, sir.
No, man. How can it be? And what is the major difference? Sanya?
So difference in the, I didn't understand
Huh?
what way. Difference in what sense, sir? I didn't get the.
You know, I didn't understand what you said.
No, sir, difference between superficial femoral artery and profunda femoris.
Yeah, how do you identify that in angiogram?
Just,
See, so it's very simple. Superficial
yes,
femoral
sir,
has no branches
continuous.
in the thigh. Profunda femoris
Gives
has
muscular branches.
three to four branches which supplies the deeper muscles and the bone. So that is how you differentiate. And usually the profunda can, I think there will be occlusion at the origin of profunda. But generally profunda femoris is less prone to developing atherosclerosis compared to SFA. Ballal sir?
No, just one comment, sir. I think there could have been a flow chart to say when will you do medical management and when do you go on to do transluminal angioplasty.
Correct.
Right, that would have been a better option than just putting these slides, sir.
Correct. I think that is the approach. See, this is
Yes.
the thing. Scientific approach to practical and scientific approach to the problem. When do you decide to do medical management? When will you go for intervention, vascular intervention?
All of us know that this is the option, yes, but when will you take this option?
Correct.
So one suggestion, sir. Can we have a class separately on management of peripheral arterial disease, sir?
Yeah, I think we should. I think we have reached almost 10 o'clock.
Yes,
so
yes,
the
sir, we can ask
vascular
surgery.
management, the surgical or vascular management will have to be in another class because
Fair.
we can't complete that now.
Fair,
Sir?
Yes, fair, sir.
I think Praveen, you have to do the next class, and as
Yes, sir.
sir said, you have to.
We'll do it
If there
elaborately.
is no
Yes, sir.
flow chart available in Rutherford, you have to make your own flow chart as to when you do medical management, when you opt for surgical management, and then we will talk about all the options in the surgical management.
Yes, sir. I'll do it, sir.
Okay.
Fair,
So I think Ballal sir, your feedback about this class, about the slides, the performance of Praveen.
Unfair, sir. I joined a little late, so unfair to ask.
No, but
Let me put it this way. You could have been better.
It's only constructive criticism. It's only for them to improve. There is no other.
No, I must appreciate the quality of the slides, sir. It was really well done slides, sir.
Correct.
But the matter could have been presented better. That's all.
Better. Correct.
Yes.
Yeah, absolutely agree with that. Sanya, what do you think of his presentation?
The presentation was good, but again, Praveen just reads the slides. He should be more put just words and then explain each of them.
So, Praveen, all of you, it is not just for Praveen. See, the bullet points on the slide is only as a guide for you to just elaborate on the each sub heading or topic that you have actually put up there. And each of these has to be backed up with literature search with the evidence base. Why do you say this particular drug is better than the other drug? You should have evidence for that. If you remember, I did a class on the management, deep vein thrombosis and DVT and everything. I gave you evidence for every single thing that I told you. So that is how you have to do the class. There should be, this is not undergraduate study. This is not undergraduate class. It's postgraduate. So you have to graduate above the level so that you know exactly, as sir said, what are the options available and when to use the options, because that is where your critical thinking comes in. Slides were good, but you can do better with your exposition of that. Okay.
Yes,
So
sir.
I
I'll
think
do
we'll
it, sir.
stop the class here.
Fine, sir.
I sincerely thank Professor Ballal for joining us. It was
Thank you,
great
sir. My pleasure. My
feedback
pleasure.
to us. Thank you, sir. Good night.
Thank you. Thank you. Good
And
night.
good night, everybody.
Good night. Good night.
Good
Thank
night.
you, sir.